You know, usually when you swallow a pill, there is this expectation of absolute mechanical obedience.
Oh, totally.
Right. Like you have a headache, you take the ibuprofen, the pain goes away,
Right.
and you just assume the drug marched into your system and flipped a very clean, clearly labeled, switch marked, headache off.
Yeah, it feels completely binary, just
I know.
cause and effect. You
Exactly.
put the medicine in and the symptom stops.
On or off. And I mean, it is very comforting to think of it that way, but we've been looking through a massive stack of pharmacology textbooks and medical histories for this deep dive. And what's wild is that the on-off switch is a total illusion.
It really is.
Instead, when you take a medication, you are actually launching a massive, chaotic turf war on a microscopic scale.
And every single person listening to this is hosting that turf war inside their body right now.
Which is crazy to think about. And that is why we are going to spend some time today unpacking exactly how that works.
Wow.
We want to demystify this concept of agonists and antagonists in pharmacology because, understanding this invisible dance like how drugs actually turn our cellular receptors on and off, it matters for absolutely everything.
From the allergy pill you took this morning to life-saving emergency medicine.
Okay, let's unpack this. How do we even begin to visualize what is actually happening when that pill hits your bloodstream?
Well, we have to start with first principles.
Yeah.
So imagine the surface of your cells.
Okay.
They aren't just smooth bubbles, right? They're covered in millions of tiny, intricate locks.
Millions of them.
Yeah, millions. These are your receptors. They're complex proteins embedded right into the cell membrane. Now, floating around in your body are the keys.
And what are those keys exactly?
These keys can be your natural hormones, neurotransmitters, or, the drugs you take. In pharmacology, we call the body's natural keys endogenous ligands.
Endogenous just meaning originating from inside the body.
Correct. So when the right key finds the right lock and fits into it perfectly, it doesn't just sit there. It triggers a cascade inside the cell.
Like a chain reaction.
Exactly.
Yeah.
It might open an ion channel or switch on an enzyme. Ultimately, it causes a muscle to contract, a neuron to fire, or maybe a gland to secrete a hormone.
Okay, I can picture that. We've got locks on the cell surface and we've got keys floating in the blood. But I noticed something crucial in the textbooks we reviewed.
What at that?
What happens when a key fits into the lock perfectly, but it just refuses to turn?
Yeah. That is where pharmacology gets complicated. That's where we have to define the core mechanics of all this.
Right.
A lot of old shorthand will just say, an agonist turns the receptor on and an antagonist keeps it off.
That's how I always thought of it.
Most people do. But pharmacologists actually define these molecules using two completely separate measurable properties, affinity and efficacy.
Which seem like two sides of the same coin, but they really aren't.
Not at all. Affinity is simply how tightly a drug binds to a receptor.
Yeah.
Think of it as magnetic attraction or stickiness.
Okay, stickiness.
Efficacy, on the other hand, is the ability to actually turn the lock. It's how much biological response that binding produces once the drug is attached.
So it's like being in the keyhole versus actually turning the mechanism.
Precisely. So an agonist is a molecule that has both affinity and high efficacy. It sticks to the lock and it triggers the cellular machinery, basically mimicking what your body's natural chemicals do.
So an agonist is like a master key. It slides in, turns the mechanism, and opens the door.
Yes, exactly.
But then you have a pure antagonist. And the sources say an antagonist has affinity, meaning it binds tightly to the lock, but it has zero efficacy.
Right, zero.
It produces no activation. So an antagonist is essentially like a broken key snapped off in the lock.
Oh, that's a great way to put it.
It doesn't open the door, but it completely prevents anyone else from putting a working key in.
That is a very accurate way to visualize it.
But I want to push back on a common misconception here. When I read that an antagonist has zero efficacy, my immediate thought was, oh, so it's a dud.
Right, like it's just broken.
Yeah, it's an inactive drug that just sits there passively doing nothing. But that's not true, is it?
What's fascinating here is that antagonists are incredibly active pharmacologically, just not in the way we typically think of activity.
Right.
Their activity is the aggressive blocking and occupying of that receptor space. Think about a crowded room where people are trying to get through a door.
Okay.
Standing in the doorway and bracing yourself against the frame so nobody else can get through is an active, physically demanding event.
Yeah, you're not just relaxing, you're holding the line.
Exactly. You aren't opening the door,
Yeah.
but you are actively denying access to the body's natural chemicals. They are holding the line.
Which honestly brings up a historical mystery that was driving me crazy while I was reading the source material.
Oh, the timeline.
Yeah, if this entire lock and key system is microscopic, how did early scientists ever figure out how to build the keys?
It's wild to think about.
We're talking about the early 1900s here, long before we had microscopes powerful enough to see individual proteins or cell membranes.
It really is one of the great detective stories in medicine. The conceptual groundwork started in 1905 with a British pharmacologist named John Newport Langley.
Okay.
He was studying muscle contractions and proposed that cells must possess what he called receptive substances.
Receptive substances, but they couldn't see them.
No, not at all. And scientists couldn't actually prove how it worked mathematically until the 1920s and 30s with a guy named A.J. Clark.
Right, the occupation theory.
Yes. Clark proposed the occupation theory, which argued that the magnitude of a drug's effect is directly proportional to the number of receptors it occupies.
So let me make sure I have this right. If a drug occupies 50% of the cell's receptors, you get a 50% biological response.
Exactly.
And if it occupies 100%, you get a 100% response.
It sounds incredibly logical, right? But there was a massive gap in his theory.
What was it?
Occupation theory couldn't explain a very glaring problem. Why could two different drugs both occupy 100% of the exact same receptors, yet produce drastically different sizes of effect?
Oh, wow.
Yeah, one drug gives a massive response, the other gives a tiny one, even though both are taking up all the available space on the cell.
Because Clark was only measuring affinity, like how many locks had keys in them.
Yes.
He wasn't measuring efficacy. He didn't know what those keys were actually turning.
Precisely. It wasn't until the 1950s that two researchers, R.P. Stevenson and E.J. Arians, independently solved this.
By doing what?
By separating affinity from efficacy in the math.
Hmm.
They proved that just because you occupy the space doesn't mean you trigger the same downstream response.
And around that same time, you have Raymond Alquist in 1948 doing something that honestly sounds like magic to me.
Oh, Alquist's work is brilliant.
He classified the body's adrenaline receptors into two categories, alpha and beta, but he did it purely by looking at which drugs were most potent in which tissues.
Right, no microscopes involved for the receptors.
He didn't isolate a physical receptor in a lab at all. He just noticed that, some adrenaline-like compounds were really good at constricting blood vessels, while others were really good at speeding up the heart.
Yeah, he just looked at the effects.
Wait, so he effectively mapped out a constellation of stars he couldn't even see just by looking at their gravitational pull?
That is a perfect analogy.
Mm.
He inferred the shape of the invisible locks entirely by studying the behavior of the keys.
That is incredible.
And it was such a radical idea that his paper was actually initially rejected by a major medical journal.
You're kidding.
Nope. But his unseen constellation became the foundation for one of the most commercially important classes of drugs in human history. And that was thanks to the work of Sir James Black in the late 1950s and 60s.
We're talking about the beta blockers.
Yes. And to understand why this was revolutionary, you have to think about what treating heart disease was like back then.
Okay, paint the picture for me.
If a patient had a diseased, failing heart, any spike in adrenaline from stress or exercise would force that weak heart to pump harder and faster.
Which sounds dangerous.
Extremely. It often led to a heart attack. So Sir James Black reasoned that if the heart's beta-1 receptors are normally activated by adrenaline, what if we designed a drug specifically to block them?
Oh, I see.
Instead of trying to find an agonist to turn a system on to help the heart, he rationally designed an antagonist to turn the system off to protect it.
He essentially said, stop whipping the tired horse, let's just block the whip.
And that logic won him the 1988 Nobel Prize.
Wow.
Yeah. The result was propranolol in 1964, the first clinically successful beta blocker, and later cimetidine to block stomach acid.
So Sir James Black designed a gentle antagonist to protect the heart from stress, but out in nature, and especially in emergency medicine, antagonists can be incredibly dramatic.
Oh, definitely.
They aren't just gentle blockers taking up space. They are the ultimate eviction notices.
They absolutely are. And one of the earliest examples of this is curare.
Right, the poison.
Yeah. Long before modern pharmacology, South American indigenous peoples used curare as an arrow poison. Animals struck by it became paralyzed and asphyxiated very quickly.
But how does it actually work? at the lock and key level, does it just destroy the muscle completely?
No. And that was the brilliant discovery of a French physiologist named Claude Bernard in the 1850s.
The 1850s.
Yeah, he ran landmark experiments showing Curer didn't harm the nerves or the muscles directly. It acted specifically at the junction between them.
The neuromuscular junction.
Exactly.
Right.
It locked into the receptor for a neurotransmitter called acetylcholine, but it didn't activate it. Because it was blocking the signal, the muscles just couldn't contract.
Wow.
Curer's active compound, tubocurarine, later revolutionized surgery. Doctors realized they could use it as a highly controlled muscle relaxant during operations. It is widely considered the original competitive antagonist.
Let's talk about that term, competitive antagonist.
Yeah.
Because it brings us to a modern drug that is in the headlines every single day, naloxone or Narcan.
Right, a very important drug.
Synthesized in the 1960s, naloxone is a competitive antagonist at the mu-opioid receptor in the brain.
Correct.
Now, contrast this with fentanyl or heroin, which are agonists. They bind, they activate the receptor to relieve pain, but at high doses, they suppress the brain's drive to breathe.
And here is the mechanical genius of naloxone. It has zero efficacy. It produces absolutely no opioid effect whatsoever.
At all.
None. But its affinity, its magnetic attraction to that lock, is overwhelmingly high.
Here's where it gets really interesting. Hold on. If fentanyl is already locked in, how can naloxone physically rip it out?
It's a great question.
Is the naloxone molecule just heavier or something? How does it actually win that fight?
It forces us to rethink how these locks work. Molecules don't just bind to a receptor and stay there forever.
They don't.
No, they are constantly binding, releasing, and rebinding in fractions of a millisecond. It is a highly dynamic environment.
Okay, so it's like a vibrating, buzzing environment.
Yes. So when you administer naloxone, you are flooding the area with a molecule that has a much higher affinity.
Oh, I see.
So the exact microsecond that fentanyl naturally unbinds from the receptor, naloxone rushes in and steals the seed. And because it sticks so tightly, the fentanyl just can't get back in.
So it is a sheer numbers game combined with superior stickiness.
Yes. It displaces a potent agonist in real time. Because it shuts off that overwhelming signal, naloxone can restore a person's breathing in roughly 2 to 3 minutes.
That is incredible.
That competitive turf war happening on the cell membrane is exactly why having Narcan available over the counter since 2023 has been such a critical tool in the opioid crisis.
So we've painted a very clean mechanical picture so far. You have agonists that turn things on and antagonists that rip them out and shut things down.
Right.
But, biology is rarely that binary. What happens when a key only turns the lock halfway?
Then you enter the gray area of pharmacology, the
Oh,
partial agonists.
a gray area.
Yeah.
Hmm.
A partial agonist is a molecule that has affinity. It binds to the lock, but it only has low to moderate efficacy. They have what we call a ceiling effect.
Okay, I need to stop you there. Because when I hear partial or moderate efficacy, my immediate thought is, isn't a partial agonist just a weak drug?
That is a very common assumption.
Like, if it's weak, couldn't I just take a massive dose of it to finally get to 100% activation?
But no, a weak, full agonist just needs a higher dose to eventually reach 100% efficacy. A partial agonist has a hard mathematical cap.
Oh, really?
It physically cannot turn the lock all the way. You could take a truckload of a partial agonist, and it might never go past, say, 40% receptor activation. It hits a ceiling.
And this brings up what the sources call the buprenorphine paradox, which is a really intense clinical hazard.
Yes, it is.
Buprenorphine is a partial agonist at that same mu-opioid receptor we just talked about. Because of that hard ceiling effect, it is much safer for overdosers.
Because it hits that cap.
Yeah, exactly. It won't suppress breathing the way fentanyl does because it just can't activate the receptor past a certain point. But what happens if you give buprenorphine to a patient whose system is already saturated with a full agonist like fentanyl?
That's the danger zone.
Does it just add to the opioid effect?
No, it causes a disaster. Because buprenorphine has a very high affinity, it rushes in and violently kicks the fentanyl off the receptors, just like naloxone does.
Because it wins the game of musical chairs.
Right. But remember, buprenorphine only has partial efficacy. So the patient goes from having their receptors 100% activated by fentanyl down to only 40% activated by buprenorphine.
Wow.
The body's net opioid signal suddenly plummets.
Which means a drug that technically turns the receptor on acts exactly like an antagonist that turns it off.
And that sudden drop triggers severe, immediate withdrawal. It's why addiction medicine providers have to manage buprenorphine induction so carefully. A drug's functional identity changes completely based on the environment it enters.
Well, if a drug's identity changing based on what else is in the system isn't complex enough, modern science found that a drug can actually change its identity based on where it is in the body.
It's amazing.
We are talking about actual shapeshifters.
Yes, and the classic example of this is tamoxifen. It has been a cornerstone drug for hormone receptor-positive breast cancer for decades.
Right.
Tamoxifen binds to the estrogen receptor. In breast tissue, it acts as an antagonist. It blocks estrogen from signaling the tumor to grow, which heavily reduces cancer recurrence.
But the exact same drug molecule floating down to the uterus or the bones does something completely different.
Totally different.
How is that even physically possible? If it's the exact same key and the exact same estrogen lock, shouldn't it do the exact same thing?
You would definitely think so. But it comes down to the wiring inside the cell.
The wiring.
Yeah. The key is the same, and the lock on the surface is the same. But once that lock is turned, it relies on secondary machinery inside the room called co-activators and co-repressors to actually send the signal.
Oh, I see.
Breast tissue has a different ratio of this internal machinery than bone tissue does.
Huh.
So in the uterus and the bone, tamoxifen actually acts as a partial agonist.
Well, wait, it turns the estrogen receptors on.
Yes, that is why it helps protect bone density, though it also unfortunately raises the risk of endometrial cancer.
That completely shatters the misconception that a drug is intrinsically just an agonist or an antagonist. The molecule is just a piece of metal. What happens depends on what the lock is wired to inside that specific room.
And that realization forced pharmacologists to create an entirely new category, selective estrogen receptor modulators, or SERMs.
Right.
But the complexity goes even deeper. In the 2000s and 2010s, researchers discovered a concept called bias agonism. They realized that a single receptor can actually have multiple, totally distinct pathways wired to it at the exact same time.
So to stick with our architecture metaphor, it's like having a doorknob where twisting it to the left pulls one cable inside the door, but twisting it to the right pulls a completely different cable.
Yes. And the holy grail of biased agonism is designing a key that turns the doorknob just enough to pull the good cable while leaving the bad cable completely alone.
Okay, that makes sense.
Which brings us to the 2020 FDA approval of oliceridine, or Olinvic. It is an opioid engineered to preferentially trigger the pain relief pathway, which runs via an internal wire called G proteins.
Right.
But it is designed to barely touch the respiratory depression pathway, which runs via a separate internal wire called beta-arrestin.
So they're trying to get the pain relief of an opioid without the fatal overdose risk of stopped breathing.
That's the goal.
That sounds like a miracle drug, honestly. But I know we need to look at all sides of the research here. The sources point out that this is highly contested within the scientific community.
It is a massive debate.
Right.
We have to impartially note that while the molecular theory is brilliant, many researchers argue that the clinical trial evidence for oliceridine actually providing a meaningfully better safety margin in human patients is just thin.
So it might not work as perfectly in reality.
Right. This raises an important question. Are we truly able to separate a drug's benefit from its harm at the exact same receptor using chemistry alone? Or does human biology simply demand a trade-off?
That's a huge question.
It remains a highly unresolved question in pharmacology today.
So what does this all mean for you, the listener? We've talked about historical arrow poisons, Nobel Prize winners, and cutting-edge opioid design.
We covered a lot of ground.
But this invisible framework is the actual logic of your own medicine cabinet.
Yes.
Every single time you use an albuterol inhaler for asthma, you are firing beta agonists into your lungs to force those airways to open.
Absolutely.
Every time you pop a loratadine for spring allergies, you are deploying antagonists to aggressively block histamine receptors from triggering a runny nose. You are manipulating this exact lock-and-key system on a daily basis.
If we connect this to the bigger picture, pharmacology isn't just a list of what drugs do to the body. It is a profound revelation about the body's incredible, intricate design. Drugs don't create new functions out of thin air. They merely hijack the magnificent, pre-existing communication networks that your cells have been using to talk to each other since before you were born.
Which leaves us with one final, deeply provocative thought to mull over.
Okay, let's hear it.
We spent this whole time talking about turning receptors on and turning them off. But in the 1980s and 90s, scientists discovered something called constitutive activity.
Right, constitutive activity.
They realized that many of your cellular receptors are actually humming along, sending out a low-level signal, even when absolutely no key is in the lock.
A baseline level of activity that just happens entirely on its own.
Right. And because of that, they discovered inverse agonists.
Inverse agonists.
These are drugs that can actually push a receptor's activity below its natural resting state. Think about what that implies for a second.
It changes everything.
We started this deep dive talking about taking a pill and expecting a clean binary off switch. But if an inverse agonist can push a receptor's activity below its baseline, it means our bodies are never truly off.
There is no zero state.
Exactly. Your cells are constantly firing, vibrating in a state of perpetual anticipation. There is no dead switch. There is only a living, breathing balance. And the next time you take a pill, you aren't just giving an obedient worker an order. You are dropping a brand new key into a symphony of millions of locks just waiting to be turned.